Hello, everyone. This is Dr. Mickey recording a lecture on chapter 21. So it's the chapter on the drugs for neuromuscular disorders, in which we're going to cover the medications or pharmacotherapy for skeletal muscle spasticity, skeletal muscle or muscle rigidity, and muscle spasms. And in other words, the management or pharmacologic management of muscle spasms. So the muscle spasms, which is the involuntary contraction of muscle or group of muscles. So the muscle spasm, either it's two different types of spasm. We have tonic spasm and clonic spasm. Tonic spasm, which is in which that there is a single muscle that will contract for a long time. So it's a single prolonged contraction of a single muscle. That's a tonic spasm. When there is a clonic spasm, that's because of multiple rapidly repeated contractions, either of one or more than one muscle. So when the muscle spasm, it locks in a contracted state. So that's spastic or spasm. So the muscle will contract in a locked state. Causes of the spasm or the muscle spasm, either epilepsy, seizures, hypocalcemia, one of the major factors contributing to muscle spasm, and different medical diagnoses. An example of this one would be patients who undergo hemodialysis due to the end-stage renal disease, because we pull all the toxins and urea and the creatinine and other waste products from the blood. We also sometimes, the machine will pull some of the calcium pulled from the blood, so patients develop hypocalcemia, and then they will complain of lower extremities spasm at the calf area, the lower extremities, on the back of the lower extremity. That's due to the hypocalcemia. Pain syndromes, either chronic or acute trauma, which due to the excessive use or a local injury of the skeletal muscle. Over medication with antipsychotics. Or you can add to the causes and etiologies for the muscle spasm also dehydration, fluid loss or fluid deficit, and the specific or certain neurologic disorders like cerebral palsy, CP, MS, multiple sclerosis, PD, which is Parkinson's disease, and TBI, which is a traumatic brain injury and head trauma or head injury. So patients with muscle spasms, they may experience inflammation, edema, pain at the affected muscles, of the affected skeletal muscle or the muscle being affected, painful sensation. They may also complain of the loss of coordination and reduced mobility. Poor circulation, an example of the poor circulation to the lower extremities, to the legs, for example, that would result in the intermittent claudication, which is a common cause of the muscle cramping or the muscle spasm in the lower legs. And that's due to, most of the time, this intermittent claudication is due to the poor perfusion, which is from the muscle spasm, or the vascular problem, which is arterial vascular disease, or PAD, peripheral arterial disease, PAD. So patients complain of this intermittent claudication due to the poor perfusion, due to the PAD, peripheral arterial disease, and intermittent in terms of on and off, which is an example of patients who complain of PAD, and they will, after they walk like a block or two, they will complain of extremely severe pain due to the ischemic attack or ischemia, and then they will stop walking, and then the pain resolved or pain will, diminish, and then they will resume walking, and then they stop because of, pain will come back again. So this is like on and off. They, walk and stop. That's why it's called intermittent claudication. And I'm going to write the claudication right here on the slide. So this is the term that you may add as a form of the pain affecting the lower extremity due to the skeletal muscle spasm in response to the low perfusion due to the PAD, peripheral arterial disease. And just going back to the neurologic disorders, one of them was cerebral palsy, and which is a neurologic condition associated with any event that occur before or during birth, but maybe also acquired during the first few months of years of life, and usually result either as trauma during, labor and delivery, or sometimes after birth. So the head trauma or infection affecting the brain, that may result in a cerebral palsy. And this cerebral palsy that may go right here under the neurologic disorders. And it's abbreviated as CP. And newborns sometimes develop the cerebral palsy from the spiking temp, like, hyperthermia, fever, especially during the first few weeks of life. That's when the brain is severely, very sensitive, affected by the high temperature, and that results in a damage to certain or specific, area in the brain, and that will lead to the CP, cerebral palsy, neurologic disease. Now, these are the spasticity versus rigidity. These are the two videos that will explain the difference between these two terms when the muscle is spastic versus the muscle is rigid, or the spasm or rigid versus spastic. And these are some of the physical measures in terms of the non-pharmacologic treatment of the muscle spasm, which we include, or sometimes the first non-pharmacologic treatment would be the application of heat or cold applications, hydrotherapy, or pool baths, or massage, or the physical therapy. And also under the camp therapy, the patients may prefer to treat minor muscle aches and spasm with herbal remedies, and like applying the application of some ointments, or some type of OTC, over the counter medications, especially the capsaicin stuff, which is very effective to treat the muscle spasm and muscle pain, or castor oil and castor oil packs. The pharmacologic treatment of the muscle spasm, which most of the time, it's a combination of analgesics with anti-inflammatory agents and centrally acting skeletal muscle relaxants. For more intense muscle spasms, most skeletal muscle relaxants relieve symptoms of muscular stiffness and rigidity due to the muscular injury or degenerative disease, like multiple sclerosis, for example. Even vitamins like vitamin B6, pyridoxine, has been found to reduce the intensity and duration of the leg muscle cramping in some patients. So it's some kind of effective result in muscle cramps or muscle spasm, the vitamin B6, pyridoxine. The NSAIDs as well, the non-steroidal anti-inflammatory drugs, also like aspirin, naproxen, ibuprofen. They are also usually the first-line drugs to treat or for treating minor to moderate pain due to muscle overexertion. So two groups of drugs that cause skeletal muscle relaxation. Skeletal muscle relaxants fall in two main groups. One group for localized muscle spasm, and we have another group for spasticity. So that will be the content for the following or the upcoming slides or content in these slides to cover these two major groups or two main groups of drugs and medications that for muscle relaxants. One is the first group is for localized muscle spasm, and the other group for the muscle spasticity. So most produce their effects through the actions in the central nervous system, CNS, except for one drug, which is dantrolene. Dantrolene, we'll get to even dantrolene towards the end of this lecture. So this is a group of medications and which that we include in this table, generic name or with the trade name or brand name, and then the usual adult dosage for usual adult one oral maintenance dosage. So the dosage for adults as a maintenance dose for adult population. So from this group, you can identify or highlight some of these medications like baclofen, Lioresal, very common drug. I'm going to cover that in a minute. We have carisoprodol, which is Soma, also a very common, widely used drug. Another one, which is cyclobenzaprine, Flexeril, very common one. Diazepam, which is the benzodiazepine Valium. It has a muscle relaxant effect. And the last one is the tizanidine, Zenaflex, is a very also effective muscle relaxant and a widely used drug as well. So we have the first group, which is the centrally acting muscle relaxants. So the skeletal muscle relaxants, centrally acting, they act at the various levels of the central nervous system, CNS. So these centrally acting medications, they will reduce pain. They will also increase the range of motion. The prototype drug is the cyclobenzaprine, which is one of the main brand names is Flexeril. So it inhibits the upper motor neuron activity and it will lead to the depression of the central nervous system, CNS, to treat localized muscle spasms. That is toxic to the liver, so it may lead to hepatic toxicity physical dependence, and anticholinergic effect. And we're going to cover physical dependence and tolerance and the addiction, concept of addiction in the upcoming lecture, which is in chapter, in the chapter 22. We have similar drugs to cyclobenzaprine, such as baclofen, crisprodol, and tizanidine and diazepam, and we mentioned these medications in the previous slide. So the baclofen, Larasil, the average or usual adult dosage will be like 5 milligrams 3 times a day, and max will be like 80 milligrams daily. The crisprodol, which is Soma, oral, 250 up to 350 milligrams 3 times a day. Tizanidine, Xanaflex, oral PO or oral dosage would be like 4 up to 8 milligrams, 4 up to 8 max milligrams of 3 times, sometimes even 4 times daily, and we have a max of 36 milligrams in 24 hours. So not to exceed the 36 milligrams daily. So the Xanaflex or tizanidine, it's a chemical classification commonly associated with drugs that treat the nasal congestion or irritation in the eyes. But it's also has, which is the off-label use, if you look at this as off-label use. But it's a centrally acting alpha-2 adrenergic agonist that will inhibit the motor neuron mainly at the spinal cord level. Then it will eventually lead to muscle relaxation. And it's very similar to the clonidine. Within this description of the chemical classification that is associated with the drugs that treat nasal congestion, and it's a centrally acting alpha-2 adrenergic agonist to inhibit the motor neuron at the spinal cord and then eventually lead to muscle relaxation. These two features or these two characteristics pertain to the tizanidine, Xanaflex, and also as well as clonidine. And also we are going to cover clonidine, which is anti-hypertensive drug in chapter 22, because it has some application in substance abuse. So tizanidine, Xanaflex is the muscle relaxant, very effective muscle relaxant. The diazepam or Valium, orally or PO, can be 4 dosage for up to 10 milligrams twice or 4 times daily. So although not classified as the antispasmodic and generally indicated for treatment of anxiety-related symptoms, the diazepam as a benzodiazepine, so which applies to other benzodiazepines like clonazepam, Klonopin, and lorazepam or Ativan, they have they're effective for muscle spasm as skeletal muscle relaxants. So the prototype drug, we said, is the cyclobenzaprine, and we mentioned and went over some of the drugs that are similar to the cyclobenzaprine, like baclofen, crisprodol, Soma, tizanidine, Zanaflex, and then diazepam Valium. So this drug is not recommended for pediatric use. And we have to use caution and be careful to prescribe it for patients older than 65 years old, because this population is more likely to experience confusion, hallucination, and other like adverse cardiac events from this drug. So that's why it's not contraindicated, but it's that we should be careful when we prescribe it to patients over to 65 years old because of these expected symptoms or adverse effects like confusion, hallucinations, and cardiac events. In other words, acute MI or ischemic attacks like angina. So the dosage for the cyclopentazepam would be like extended release dosage of oral medication will be 15 milligrams once daily. We can give a max of 30 milligrams daily. So here's the adverse effects and the contraindications, interactions, drug-drug interaction. So alcohol, phenothiazines, and other CNS depressants may cause additive sedation. Become more sedated, the patient, when we add any of these medications or drugs or agents to the cyclopentazepam, or given concurrently, simultaneously with the cyclopentazepam. So the cyclopentazepam should not be used within 2 weeks of the MAO inhibitors or the monoamine oxidase inhibitor therapy, because that may lead to the hyperthyroidic crises, hyperthermia, and convulsions that may occur as well. So to treat the overdose, the IV administration of 1 to 3 milligrams of physostigmine. It was reported when we give the physostigmine 1 to 3 milligrams IV that it will reverse the symptoms of poisoning or overdose by this drug, because that's an anticholinergic activity. So this drug, cyclopentazepam, has an anticholinergic activity. We treat it with the cholinergic drug like physostigmine, which explains why the physostigmine also will be prescribed for or given to patients when they develop the atropine overdose or atropine toxicity. Atropine is an anticholinergic drug. Same thing as cyclopentazepam has also anticholinergic activity, same thing. So that's why physostigmine is the cholinergic, which can be given as an antidote or to reverse the symptoms of the cyclopentazepam, as well as for atropine overdose as well. So that's why physostigmine may be helpful in the treatment of cyclopentazepam overdose. So diazepam, the mechanism of action, it will enhance or through enhancing the effect of the GABA receptor in the brain. Tizanidine or Zanaflex, mechanism of action through the agonist action at the presynaptic alpha-2 receptor. So it's alpha-2 receptor agonist centrally acting in the brain as well. So the tizanidine will relieve the local muscle spasm, decrease local muscle pain, increase range of motion, um, and we can use diazepam or tizanidine because no studies to indicate superiority of one drug over another. So tizanidine or Xenaflex promotes the inhibition by acting as an agonist at presynaptic alpha-2 receptors in the brain. Adverse effects will include the following: generalized CNS depression, obviously because the drug depresses the central nervous system, hepatic toxicity, especially the xanidine, it can cause liver damage, and the other similar drugs like Relaxant and Paraflex also may cause hepatitis and necrosis in the liver, but we'll just focus here on the tizanidine Xenaflex as a widely or commonly prescribed drug. And also it may lead to physical dependence. In other words, it's the abstinence syndrome or the withdrawal symptoms when patients stop taking the drug. Baclofen, which is Lioresal, acts in the CNS, spinal cord. It suppresses hyperactive reflexes, so it will lead to more relaxed muscles. And also, it mimics the action of the GABA receptor in the spinal neurons. And that's the exact mechanism how the Lioresal will lead to muscle relaxation. So the baclofen Lioresal indications or therapeutic uses for multiple MS, multiple sclerosis, spinal cord injury, and cerebral palsy. Very effective for these three conditions. It decreases the flexor and extensor spasms. It suppresses resistance to passive movement, but it's not recommended for patients with stroke or CVA. Adverse effects, there is no specific antidote for baclofen overdose or toxicity, and the gradual withdrawal over 1 to 2 weeks. So we recommend just when we stop, when we plan to discontinue the drug, not to be abrupt or sudden, to stop the drug, not to be very, abrupt withdrawal, because the patient may lead. So again, especially with the drug that is given intrathecal drug. In other words, it's through the catheter and the spinal cord or spinal CSF fluid. So abrupt intrathecal withdrawal may lead to the risk of rhabdomyolysis. So again, it's recommended that we withdraw or when we stop the drug, not to be abrupt and sudden. So it be gradual withdrawal and to be over like 1 to 2 weeks. It's like tapering off the drug and eventually to discontinue the drug after 1 or 2 weeks. So because the abrupt intrathecal withdrawal, this is a drug is going to be infused through a catheter into the CSF fluid, and the abrupt withdrawal of the intrathecal withdrawal will lead to rhabdomyolysis, which is a significant breakdown of the muscle, and the breakdown of the muscle will lead to myoglobin, and myoglobin will cause liver damage, kidney damage, renal damage to the kidneys, and we can indicate this or we can diagnose that, from even the manifestations of a dark urine, from the presence of the myoglobin in the urine. And we'll explain more about the rhabdomyolysis and later on. Other adverse effects of Larasil or baclofen is CNS depression or suppression, GI symptoms like nausea, constipation, and urinary retention. So the first question, a nurse has admitted patient in the hospital or to the hospital, and the patient reports taking oral baclofen, but stopped taking the drug the day before admission. The nurse would be correct to anticipate which adverse effect. So the answer is C, seizures and hallucinations. And the rationale for that is that the abrupt discontinuation of the baclofen or Larasil is associated with visual hallucinations, paranoid ideation, and seizures. And later on, we'll talk about the intrathecal withdrawal. So this is the other route of administration, which is the oral baclofen, that's going to result in different manifestations or different adverse effects. But the intrathecal withdrawal of the intrathecal baclofen, that's the will lead to rhabdomyolysis. So here we said the abrupt discontinuation of baclofen is associated with visual hallucinations, paranoid ideation, and seizures. Now, central nervous system effects of baclofen include weakness, dizziness, fatigue, and drowsiness. But the respiratory depression is the result of overdose of baclofen, not the withdrawal or sudden cessation or sudden stopping to abrupt discontinuation of the drug. Second question, a nurse is caring for a patient receiving intrathecal baclofen, Larasil, so the patient is unresponsive after asking for a coworker to contact the provider. The nurse anticipates performing which intervention? So the answer is A. So an overdose of baclofen can produce coma and respiratory depression. So the nurse would be correct to suspect overdose in this patient. Respiratory support is essential to prevent a fatal outcome. There is no, as we mentioned earlier, is that there is no antidote for baclofen overdose. Diazepam would not be indicated here because seizures are not a result of baclofen overdose and may further depress respirations. An electrocardiogram is not indicated for this patient either. Next question, the nurse on an orthopedic unit routinely cares for patients receiving carisoprodol, which is soma. For which adverse effects should the nurse monitor these patients? Select or apply. So carisoprodol soma is centrally acting skeletal muscle relaxant, and as such can produce generalized central nervous system depression, CNS depression. So these agents or medications may also cause physical dependence when taken for long term or in high doses. So the answer is A, drowsiness and sedation, and C, risk of dependence. Next is the spasticity, which is associated with certain diseases like MS, multiple sclerosis, in which that spasticity, which is a condition in which muscle groups remain in a continuous state of contraction, like prolonged contraction. So prolonged contraction with no relaxation. So the contracted muscles become stiff with increased muscle tone. And other signs and symptoms with the spasticity with a spastic muscle would include the mild to severe pain, exaggerated DTRs, deep tendon reflexes will be exaggerated, and then localized muscle spasm with sometimes the involuntary crossing of the legs, which is called scissoring, from scissor, involuntary crossing of the legs, and also affixed joints. And I think that some of you have seen or observed or took care of patients who are really contracted at the elbow or at the knee joint, and also the hip as well. When they are contracted, that's spasticity due to the neuro, muscle, multiple sclerosis, or other neurologic disorders. So spasticity usually results from damage to the motor area of the cerebral cortex that control muscle movement. And the etiologies most commonly associated with this condition would include CP, cerebral palsy, severe head injury, or which is TBI, traumatic brain injury, spinal cord injury, or lesions like brain trauma to the spinal cord, lesions, tumors, stroke, or CVA. So the spasticity, it can be very distressing and greatly would affect an individual's quality of life. And in addition to cause that will lead or cause pain, impaired physical mobility would influence the ability to perform the ADLs and diminish the patient's sense of independence. So here are, this slide includes also the most common causes, as we mentioned earlier, of the spasticity or etiologies for spasticity when the muscle becomes spastic. And the three main medications to treat spasticity. One of them is dantrolene, Dantrium, which acts directly on the smooth muscle. And we have also another one, which is baclofen layer cell is effective, and diazepam Valium is effective as well. But it's the baclofen and diazepam both at the CNS level. So dantrolene sodium or Dantrium, which acts directly, as we said, it's actually both. I mentioned earlier about the Dantrium or dantrolene acts on the smooth muscle, but also as well as the skeletal muscle. So it interferes with the release of calcium ion in skeletal muscles, and it suppressed the release of calcium from the sarcoplasmic reticulum. So the dantrolene, it relieves spasticity by interfering by the it interferes with the release of calcium ions and the skeletal muscle. So the calcium release from the SR, sarcoplasmic reticulum, it's necessary for skeletal muscle contraction. So if the release of this calcium is blocked, then the muscle tension will be reduced. Which, in other words, this is like exact mechanism of action of the dantrolene, how it lead to skeletal muscle relaxation. How does the spastic muscle lead or become more relaxed? Is that the dantrolene relieves spasticity by interfering with the release of calcium ions in skeletal muscle. The calcium release from the SR is necessary for skeletal muscle contraction. So if the release of calcium is blocked, the muscle tension will be reduced. So the primary use for the dantrolene which is to relieve the dystonias and leg cramps. And when we see dystonia, which is a disorder characterized by involuntary muscle contractions that cause slow, repetitive movements or abnormal postures. And on the right side of the slide, you will find four different. It's an image or figure of four different positioning. Either it's decorticate or decerebrate positioning. So the decorticate, like an A, which is inward contraction or contracted upper extremities, and decerebrate, which when there is a outward postures or outward contraction or contracted extremities. It may affect either one side or sometimes both sides of the body. So again, dystonia is a chronic neurologic disorder, is characterized by continuous involuntary muscle contraction that would force part or body parts into abnormal, occasional painful movements or postures like these, one of the four postures, the corticate or the cerebrate postures. It affects the muscle tone of the arms, the legs, trunk, neck, eyelid, face, even vocal cords. So there are different forms of dystonia, but that's dystonia. And that's a mechanism of action of direct acting antispasmodics, pathophysiology. Actions and uses of dantrolene, sodium, or dantrium. So we said to relieve dystonias and leg cramps, and we defined the dystonia earlier. Spasticity associated with multiple sclerosis, cerebral palsy, spinal cord injury, and also as the drug of choice and the first line of management for malignant hyperthermia. And if you recall that, in the previous chapter in the anesthetics or anesthesia agents, we said that the malignant hyperthermia can result from the succinylcholine, a muscle relaxant drug, or general anesthetics or anesthesia. This is an adverse effect or adverse um, uh, side effect from or complication from the use of either succinylcholine, scoline, muscle relaxant, or the general anesthetics and during surgery. So it's a potentially fatal condition, and again, that's either caused by succinylcholine or by the general anesthetics. Questions. Which patient should receive dantrolene with caution? So we have to be careful with which of the following patients when we give dantrolene. Given that dantrolene So the answer is C. First of all, that's a 55-year-old woman with multiple sclerosis. And the answer is C? Because the dose-related liver damage associated with the dose, that's the most serious adverse effect of dantrolene and is most common in women older than 35 years of age. So the answer of C is based on the knowledge base that the dose-related liver damage is the most serious side effect or adverse effects of dantrolene and is most common in women older than 35 years. So dantrolene is used to treat spasticity associated with multiple sclerosis, cerebral palsy, and spinal cord injury. So all of these patients would be candidates for this drug. And also it can be used to treat the malignant hyperthermia. As we said, it's the first line of management or drug to treat malignant hyperthermia. Next question, which drugs are used to treat spasticity? Selected apply. So the drugs that would treat spasticity among the five drugs or agents would be baclofen, dantrolene, and diazepam. So three drugs, baclofen, dantrolene, diazepam, are used to treat spasticity. Baclofen and diazepam are because they act in the CNS, whereas the dantrolene act directly in the skeletal muscle. So dantrolene directly on the skeletal muscle, but the baclofen and diazepam at the higher level, which is a CNS level. And eventually that will lead to muscle relaxation. With the exception of diazepam, drugs used for muscle spasms, such as the metaloxone or the xanidine Xanaflex, are not effective for treating spasticity. They are good for muscle spasm, usual muscle spasm, but not for specific spasticity associated with diseases like multiple sclerosis, cerebral palsy, or spinal cord injury. So drug-drug interaction, dantrolene interacts with many other drugs. Should not be taken with OTC cough preparations and antihistamines, alcohol, or other CNS depressants. Verapamil, diltiazem. Verapamil and diltiazem, both are CCB drugs. So verapamil, diltiazem, and other CCB drugs, calcium channel blockers, that are taken with dantrolene, they may increase the risk of ventricular fibrillation, VFib, and cardiovascular collapse. Ventricular fibrillation, and cardiovascular collapse may result when we simultaneously or concurrently give the verapamil or any CCB drug, calcium channel blocker given with dantrolene, that may lead to VFib or cardiovascular collapse. So the neuromuscular blockers, there are two main groups of neuromuscular blockers. In other words, it's muscle relaxant. It's the muscle relaxant. Neuromuscular blockers. So it's a muscle relaxant. So used to relax muscles during surgical procedures. They attach or bind to the nicotinic receptors located on the surface of skeletal muscle fibers. So they will interact with the acetylcholine. And we explained the life cycle of acetylcholine in Patho Pharm 1 when we covered the cholinergic and anticholinergic and the muscle how is acetylcholine attached to the muscle and lead to contraction of the muscle. And I will briefly just go over that in a minute. So patient can still feel pain for surgical procedures, and anesthetic agents also used. So we have two groups. One will be the non-depolarizing muscle blockers, and we have another group of muscle relaxant called depolarizing neuromuscular blockers or neuromuscular blocking agents. So depolarizing versus non-depolarizing. The depolarizing, they bind to acetylcholine receptor and produce a state of continuous depolarization to cause total skeletal muscle paralysis. So just briefly, we're going to review the life cycle of acetylcholine, and if we look at the acetylcholine, the life cycle. So acetylcholine, this is the presynaptic. So we have neuromuscular junction right here. The whole thing is neuromuscular junction. This is the end of the muscle, and this is the end of the neuron. The end of the nerve or the neuron, the end of the muscle. So the vesicles and the presynaptic or neuron, presynaptic neuron will release from the vesicles, release the acetylcholine. One, it's completely manufactured or made or synthesized, is going to be stored in the vesicles, and then it will be released to attach. This is the cliff or the neuromuscular junction, and then it should attach to the receptor, the acetylcholine receptor at the nicotinic receptor of the muscle, the end of the muscle. So that's the muscle will contract. So that will lead to contraction of the muscle. So we are going to block the acetylcholine. So that would lead to muscle relaxation. So this is a depolarizing muscle, depolarizing neuromuscular blocking agent. So, and if we are going also to review the life cycle, again, we said that the acetylcholine will bind to the receptor, and the acetylcholine, the end, like the last stage of the life cycle of the acetylcholine life cycle, is that there is an enzyme called acetylcholine esterase enzyme. This one is going to degrade and break down acetylcholine into choline and acetate. So that will be the end of the acetylcholine life. So that's the life cycle. Now, if you recall that, in Patho Pharm 1, we went over some of the medications that are going to interact or increase acetylcholine at the junction, like multiple sclerosis or myasthenia gravis, that we have medications that will interfere with this enzyme, acetylcholine esterase enzyme. So back to the muscle relaxants. So we said that we have two different groups. One is called non-depolarizing, and the other one is depolarizing neuromuscular blocking agents. So the depolarizing neuromuscular blocking agents, like succinylcholine or scoline. So succinylcholine is one of them. It will bind to the acetylcholine receptor, bind here, and the drug would produce a state of continuous depolarization to cause skeletal muscle paralysis. So in other words, it will lead to complete relaxation of the muscle. And that's when we use succinylcholine during the, induction for the surgery, for intubation, that will lead to complete relaxation of the muscle. So this action first results in small fasciculations or brief repeated muscle movement. Fasciculations means just a group of fibers of the muscle, and that will be followed by relaxation of the muscle tissue. So these depolarizing muscle blockers, like succinylcholine, they are used primarily to, from the bottom we have the drug, the succinylcholine, which belong to the depolarizing neuromuscular blocking agents. So these depolarizing muscle blockers, such as like this succinylcholine drug, they are primarily used to relax the muscles of patients receiving ECT in NUR323 mental psych, course. You will go over the ECT, the electroconvulsive therapy. So the electroconvulsive therapy we can use also the succinylcholine to relax the muscles, for those patients who are taking the ECT. And also we will give succinylcholine for short surgical procedures, short term, short duration. For surgical procedures, we recommend using succinylcholine. 15 minutes, surgery, 30 minutes, even an hour surgery, can give succinylcholine. So, or for mechanical ventilation and endotracheal intubation. But more recommended during the short term, like I would say even maybe 1 hour is too long. It's like quite long, prolonged surgical time. So it can be like good for like 15 minutes, 30, up max of 30 minutes, I would say. So again, so it's for short surgical procedures, for example, like mechanical ventilation, endotracheal intubation, or short-term surgeries. The other group of medications, which is the non-depolarizing muscle relaxants or non-depolarizing neuromuscular blocking agents, they compete with acetylcholine for the receptor. So which include the top box, which is most common drug is going to be the pancronium pavilone. You can use it as take it as or use it as a prototype drug for this group. But all these 7 medications in this table, it's the non-depolarizing blockers, but the most common one is the pavilone, which is pancronium. So as long as the drug, we said that the non-depolarizing, they compete with acetylcholine for the receptor. So as long as the drug interfere with the binding of acetylcholine because it competes with the receptor, the muscle remain relaxed. So that will lead to continuous relaxation of the muscle as if it's being paralyzed. So the classic example of that, we said it's the succinylcholine. I'm sorry, it's the pancronium. So the non-depolarizing medications like the pancronium used to relax muscles of patients being prepared for longer surgical procedures. So for longer procedures like brain, GI or neuro, or like in an hour or longer than an hour surgery, 2 or 3, 4, 5 more hours of of surgical procedure, we recommend using the pancronium pavilone or any other from the list, because they are all similar. But again, the pancronium is the most common one. But the so although not preferred for mechanical ventilation or ET, we recommend that succinylcholine is given for short procedures. So like in ET, endotracheal intubation or mechanical ventilation. So here with this group, the non-depolarizing, in which that we recommend the use of this drugs from this group to relax muscles of patients being prepared for longer surgical procedures, is that although not preferred for mechanical ventilation or ET, endotracheal intubation, small doses of these drugs may be used for intermediate surgical procedures. And what we mean by intermediate surgical procedures, that may last for like an hour or 2 or 1 hour, 30 minutes. That will be like intermediate surgical procedures. So the concern or the concerns with with of these medications is over relaxation of the muscles. Over relaxation of the muscles. So because as examples, normal breathing activity like involving the diaphragm, glottis, and the intercostal muscles, and the swallowing activity involving the neck and esophagus muscles, they require contraction of a skeletal muscle, and those actions may be impaired by these drugs. Questions. The patient who has lower back injury exhibits muscle spasm. The provider orders cyclobenzaprine, Flexeril, 10 milligrams 3 times a day. What will the nurse include when teaching this patient about this drug? So the answer will be C. Cyclobenzaprine. It has a significant anticholinergic effect, and patients should be warned about the dry mouth. And the medical term for dry mouth is xerostomia, dry mouth, blurred vision, constipation. Even you can add also to the list the urinary retention. All of these are significant symptoms or manifestations or adverse effects of the anticholinergic activity. So anticholinergic effect will include the dry mouth, xerostomia, blurred vision, constipation, and urinary retention. The tizanidine or Xenaflex, it can cause hallucinations and psychotic symptoms. And it can cause liver toxicity, which requires the monitoring of the hepatic function. Now, a patient has localized muscle spasm after an injury. The prescriber has ordered tizanidine Xenaflex to alleviate the spasms. When obtaining the patient's health history, the nurse should be concerned about which possible reason for considering another drug. So we are going to look at the, as we answer the question, looking at the potential problem or adverse effect like hepatotoxicity. So B is the correct answer. History of hepatitis. Hepatotoxicity is a serious potential problem in patients receiving tizanidine, Xenaflex, because the drug can cause liver damage. So in this case, the baseline liver enzymes, liver function tests, AST, ALT, alkaline phosphatase, bilirubin, all these liver function tests are liver enzymes, and LFT, including the liver enzymes, baseline, should be obtained before the first dose and then given, and then after that, periodically, every like 3 months or 6 months or once a year, depends on the liver function or dysfunction, if there is a dysfunction status. The analgesic, the anti-inflammatory drugs commonly are used in conjunction with centrally acting muscle relaxant. So using the aspirin is not a concern. And this drug does not contribute to malignant hyperthermia. And we said that malignant hyperthermia is usually result either from the use of the general anesthetics or from the succinylcholine. So patients should be advised to avoid alcohol when taking this drug, but a history of occasional alcohol use is not a contraindication. So the nurse knows that, the next question, the nurse knows that the priority nursing interventions and teaching for a patient receiving centrally acting muscle relaxant are related to. Central nervous system suppression or depression, a concern will be safety. So centrally acting muscle relaxants can produce generalized depression of the central nervous system, CNS. Drowsiness, dizziness, lightheadedness are very common from using these medications. So patients should be warned not to participate in hazardous activities, especially like driving. If the CNS depression is significant, then should be warned not to participate in hazardous activities. They also should be advised to avoid alcohol and all other CNS depressants. Next question, the nurse should teach a patient who is prescribed centrally acting muscle relaxant to avoid which drug? And the answer obviously is going to be diphenhydramine A. Next question, the resident is writing orders for hospitalized patient. The nurse would consult the prescriber if baclofen was prescribed to relieve muscle spasm for a patient with which condition? And the answer is stroke or cerebrovascular accident, CVA. And there is a math question down here, which is dantrolene 250 milligrams by rapid IV infusion is prescribed. The recommended dose to treat malignant hyperthermia is initially 2 milligrams per kilogram. The patient weighs 185 pounds. Is this safe dose? Would see the answer is no, because the safe dosage is 210 milligrams, and you can do your math and calculation and find out that it's not a safe dose. For the case studies, the answer for these case studies will be posted in Blackboard, and this concludes the lecture.